Welcome, Dr. David Hoyt, the Executive Director of the American College of Surgeons, to our video interview series from the front lines.
Good morning.
For those listeners and viewers who may not be familiar with the American College of Surgeons structure and composition, perhaps you could start by giving us a brief outline of the composition and structure of the college.
The college is over 100 years old. It was established to really try and set standards for surgical care. And it has also evolved into being the house of surgery. As surgery has broken into more and more pieces and specialty pieces, the college continues to try and convene around surgical issues, everybody that's practicing surgery. We do that with our governance structure, which includes a board of regents that are representing a number of surgical specialties in addition to general surgery. We do it through our board of governors, which is both regional governors and then society governors covering almost 250 people. We do it through our chapters, which then gives local coverage as well. And the idea is to be a house that convenes issues that are important to surgical patients and surgeons serving those patients.
Well, certainly there were many, many issues which immediately rose with COVID-19 that required a lot of communication with surgeons and a lot of actions taken on behalf of our patients. Could you please describe how the college was well poised to offer that service and how the college accomplished what it did in such a quick time?
Well, in responding to this event, we just built upon the infrastructure that we have, which again is designed to try and serve all, not just all patients, but serve everyone involved in surgery. So if you look at the constituency that serves patients in this country, that includes large academic medical centers, hospital-based integrated medical groups, people in private practice, and every size of hospital, from a 30-bed critical care hospital to a 1,000+ bed academic medical center. So we really have to try and create issues that are common to all those and then help go about solving them. And they do require tailoring those solutions to the area where we are. Across medicine in general, we also collaborate. And so in surgical issues like the COVID crisis, hospital administration, nursing, anesthesiology, all of our partners in taking care of patients have to be involved. So again, we can become a very useful way to convene those groups to come to consensus about an issue that affects us all.
One of those groups, which I believe had a significant impact when we were initially discussing decreasing surgery and only offering surgical services for patients with urgent problems, was the Surgical Coalition. Could you please let us know what is the Surgical Coalition and what's the role of the ACS in that coalition?
Now, the Surgical Coalition was started about 12 to 15 years ago. It was actually started by Christian Shaljan, who's our lead director in Washington. And it was designed to bring surgical specialties and anesthesia together to deal with issues that affect us at a government level, or issues regarding payment and finance and all the other technical details of healthcare delivery today. And what it's become then is a group that allows us to take an issue, come together as surgical specialty organizations, and then try and find a solution. So there are many things we work together, and this most recent event with COVID-19 has been another example where we could come together and try and solve problems together.
What's the relationship between the college and the folks in Washington, D.C., who are ultimately creating the laws and enacting the policies that allow us all to practice and take care of our patients?
We have a very, very strong presence in Washington, and it's been built over time. It's based on 4 different areas. So legislative, we don't do a lot of that, but occasionally there's a piece of legislation we might advocate for or even propose ourselves. Where we spend a lot of time is on the regulatory side, and we have a very strong relationship with the regulatory agencies because we offer solutions rather than just complain about things that we don't like. And so that's allowed us to build a trust that allows them in turn to reach out to us to ask for solutions. So during this COVID epidemic, for instance, CMS and many of the other regulatory agencies reached out to the college to help develop triage guidelines to ramp down surgery. And just in the last week, they have done the opposite. They've reached back out to us to ask for help in how to put together a plan that has consistency and has support to ramp surgery back up.
I'd like to pick up on that theme of ramping back up because the college had, as you stated, clearly played a major role in the ramping down and helping people figure out what's urgent, what isn't. But the next phase is ramping back up. And perhaps you could describe to us some of the recent efforts of the college in that regard.
Sure. Well, ramping up is complicated because it has to balance safety to patients, safety to healthcare providers and surgeons and nurses in particular. It has to recognize that this has been a tremendous burden to patients to have their surgery delayed, and it's had a significant financial impact to hospitals and individual practices. So everybody wants it to return to normal, but we have to do it in a way that assures that it will be done safely. So that is right now focused on assuring that there's adequate testing, ensuring that the workload that needs to be accommodated to ramp back up to normal can be done in a systematic way. And it has to be then adjusted to the local environment because the incidence and peak and therefore ongoing exposure risk of this epidemic is different in different areas of the country. So what you're going to see is a slow process that tries to incorporate all those things and bring it up across the country over the next weeks to months.
One of the things you mentioned earlier is the college is the resource for large hospitals, over 1,000 beds, as well as for smaller rural places. What are some of the efforts that the college has undertaken recently in helping surgeons continue to practice in those different environments? And some of that may be financial and some of it may be just advisory, such as PPE.
Well, the Congress and the executive branch has created some incentive programs, which I think most people are aware of, that are aimed at trying to support, in particular, the workforce, so that a small practice that has employees can afford to pay their employees during this period of time and not go out of business. So the college has tried to help, particularly people in private practice, understand how those programs work, help them with the application process, and educate them about assuring that they participate in those. The college has also helped with the issues of concern regarding medical liability, where delaying surgery or starting surgery back once they do, there are going to be issues that are potentially putting surgeons at risk in terms of decision making, et cetera. And we've advocated for protecting surgeons as well as patients during that period of time. So there are many things that we try and look out for on behalf of surgeons so that they can go about doing their job of taking care of patients.
And as you say, that period of time, but we don't necessarily know what is that period of time. And it may well be that what we're experiencing now is a little like what we experienced in the early to mid 1980s with AIDS, where we suddenly changed what we did to universal precautions because everything had changed, or certain changes we've made to our lives after 9/11 that seemingly will never revert to pre 9/11 levels. So how do you envision the surgical, two parts to the question. The first one is, how do you envision the surgical practice changing in the future if COVID-19 is here to stay?
Well, I think from the standpoint of an ongoing concern over an epidemic, I think we will change our healthcare delivery system in the United States dramatically to be better prepared for the next time. The fact that we have had problems with supply lines for personal protective equipment, that we've had a lot of disagreement initially at what phase we were in, et cetera. Those are things that I think we'll become better educated about, and we will create a system that will be more a nationalized system to deal with the next event that occurs, because something else will occur, and we need to be better prepared. So there are already conversations that will be based on sort of after action reports, analyzing what went right, what went wrong during this epidemic, and I think our healthcare system will tailor accordingly. The other thing that's going to change is the actual delivery of care. And I think a number of things, the fact that you and I are having this interview here as opposed to in a studio or in a room, and we're close to 1,500 miles apart, that is a phenomena that we've had, but I think everybody has learned to appreciate the value of telecommunication. And I think that's going to help significantly in terms of the efficiency of the healthcare system. It allows us to do post-op screening, post-op care, many other aspects of primary care with video monitoring. And I think that will give increased access to patients to the services they need. There'll be other things that'll change. And I think, as you say, this is going to change the way we exist in this world. And I think it's going to affect medicine in the same way.
So the second part of the question, and you briefly touched on it, the telecommunication, and that has to do with meetings and with education. And we've all, on an administrative level, certainly with the ACS, who will fly to the college for a couple of hours or a day or two to do a meeting. And then there are the folks, even folks in leadership also involved in education, but for the 80,000 members and fellows who take advantage of the many educational offerings of the college, it's often in person. How do you envision changes long term based on what we're experiencing now with telecommunications?
Yeah, I think that's a great question, Suze. I actually think that's probably one of the most profound things that will change. And so, for instance, we have an incident command meeting once a day, have for the last month, where we have 45 people coming together every morning and talking about what's going on and coordinating our efforts. We do that now by televideo. In the past, we've done that by a physical meeting. Oftentimes, people can't be there, therefore they miss it. We have not always offered that capability. And I think what we've learned is that we are much more efficient. We're on top of issues more consistently. And so I think in that kind of example of internal operations, we'll probably use that going forward. Talk about travel. I mean, there are many a time you and I both end up getting on an airplane and spending half a day to fly for a 45-minute meeting, even occasionally gets curtailed because of something else, particularly in areas like Washington where people are busy and you can't always plan. Those kinds of things in the future just need to be done by televideo, because it's an incredible waste of all of our time to do that. So I think that will fundamentally change as well.
And what about the educational piece for folks who are learning? You have everything from CSAP to hands-on and simulation to postgraduate courses and congresses, educational meetings like the Quality and Safety Conference, to name one. Do you envision changes in those arenas as well?
I do. I think it's going to be important to preserve some kind of social interaction. I think we all benefit as colleagues and as a profession because of that. But certainly, for those that can't attend, we need to have ways to preserve content so that they can take advantage of it when they have the time. I think it will allow us to actually take whole pieces that we've traditionally done only by face-to-face meetings and transfer them into other delivery mechanisms. I think it's going to be important that people can do it on a smaller device like their phone, so they can do it when they have time, if they're riding the bus to work, or they have a down moment between cases during the day. There's so many times that we use time that we have during the day to do other things. And if we have the content in a platform that we can deliver it, then I think people will use it. We're going to have to learn how to do that. There are certain platforms that are popular. There are certain that are less popular. But that's a transformation that the college has started, but we need to take it even more intensively over the next couple of years.
Well, the college has been a leader in many, many facets of education, of advocacy, and other areas, and see no reason why we wouldn't again lead in this effort. Thank you very much, Dr. Hoyt, for your wisdom, your insights, your leadership of surgery, not just in the U.S., but throughout the world. I appreciate your time in this interview. Despite all the wonders of technology, I do look forward to seeing you in person, hopefully in the not too distant future when we can all travel again.
Well, thank you, Steve, for all the contributions you've made in communicating with our fellows over the last several weeks, because it's really, really important, and I appreciate all you've done as well. Thank you.